I want to thank the organizers of the meeting for inviting me. It's really a privilege to be here and a privilege to be able to speak after Dr. Aberle. What I hope to do is describe to you the Cleveland Clinic's lung cancer screening program. My hope is to demonstrate the practical questions that any program will have to answer when trying to implement a high-quality program, reflect on what some of our answers have been and what some of the consequences, for better or worse, have been based on those answers. I don't intend to suggest that our way of answering those questions is the right way. There may be better answers depending on where you're practicing and what your resources are. But I think all of the questions that we've had to answer will apply no matter where you're setting up your screening program. So the basis of a lot of the questions is an understanding of the evidence that's been so nicely already given to us all through the experts who've developed it. An understanding that this evidence suggests the balance of benefit to harm favors benefit, but this balance is somewhat tenuous. And if you make decisions that may lead to more harm, you may shift this balance entirely the wrong way. For example, if we were to enroll higher risk patients, we will screen fewer people, have fewer lung nodules found for lung cancer death averted, and the balance will tip more in favor. If we were to screen lower risk individuals, that balance may tip the opposite direction. If we are able to manage lung nodules better than was done in the National Lung Screening Trial, fewer scans, less morbidity from our testing, then the balance will tip in favor. Whereas if we make choices that end up managing nodules less effectively, the balance will tip the other way. If we don't follow radiation parameters for our imaging, we will tip the balance the opposite direction. We also have to recognize that the balance here has two sides, and the value that someone places on either side is going to be different. The mortality benefit is different than some of the harms we're describing. And so where that fulcrum is placed will shift depending on our patient's values, depending on the impact of the other findings from the CT imaging, and depending on how successful we are with our smoking cessation interventions. There is some guidance to help answer these questions. This policy statement from the two major pulmonary societies lists 9 components of a high-quality lung screening program that we would need to consider as you're developing a program. The CMS determination also gives us a lot of guidance, both about the risk group that should be screened, about the value of shared decision-making, about the value of collecting and analyzing data about your program's quality, about the experience the readers need, and about the techniques and reporting that's necessary to have a high-quality program. We have some guidance about how to implement the program once you've answered those questions. Again, from our major pulmonary societies, divided into a planning phase for the program, an implementation phase for the program, and a maintenance phase. And I'll discuss each of the questions within that framework. So this is our screening program. Our screening program has evolved over time. Each of the questions in the left-hand column I'll address in more detail. And to summarize our initial plan compared to where we are today, we started as a rather decentralized program where anyone in our health system could order the screening test. We had developed an automated data collection system, so on the back end we could track the quality of management of the patients who were being screened. Was it the right group? Was communication adequate? Are they being followed appropriately? And we learned over time that there was a lot of room to improve on those measures. As we started to centralize the program more and more, order the follow-up tests ourselves, contribute to the communication piece, the CMS determination came out, and it gave us enough backing to fully centralize our program. So now the ordering providers can only order a consult to the screening program, not the actual CT test. And we coordinate the visit with the test, and we pre-screen our patients. Now the shared decision-making occurs at the program level rather at the provider than at the provider level. all of the findings are owned by the program rather than the provider. We follow them all, schedule consults, schedule follow-up tests. Smoking cessation is also owned by the program. It's not that the provider can't still talk about the risks and benefits of screening or provide their own smoking cessation counseling, but now we take responsibility for doing that ourselves. So look at each of these questions in turn and explain what our answers to them have been, and then some of the consequences from those answers. So first, who to offer lung cancer screening? I think every program will have to consider who are you going to screen, what are your local provider coverage policies, what are you going to do when a symptomatic patient comes to your program, and how are you going to handle patients with severe comorbidities who you question the value of screening. Our approach is that we've followed CMS guidelines for Medicare patients, and rarely we get someone between 77 and 80 with private insurance that we would follow USPSTF guidelines for. We've attempted to develop a research arm for high-risk patients who don't meet the current screening criteria. We've developed a list of local provider coverage policies in our area. When a patient comes to us and we evaluate are they symptomatic or not, we own their symptoms and direct them down a diagnostic pathway if they don't meet screening criteria. And we've had lots of discussions with our pulmonary and cardiology stakeholders about who may be too sick to benefit from screening. How do we identify the proper risk group? I think every program will have to answer, how are we going to educate referring providers about who should be screened? Can we develop electronic health record tools to help us with that? And how will we educate patients who may be interested in being screened? Our approach has been multifaceted and repeated. Probably the greatest lesson I've had in developing and evolving this program is that there's never enough education of the people who are using the program. Grand rounds presentations, individual office visits, we've had newsletters sent throughout our health system, we have web-based overviews and decision aids, on-hold messages on our phones, health fairs and journal articles have all been included in our strategies. We developed a reminder system for our electronic health record, and we've attempted to mine patient data from our electronic health record. We've developed pamphlets, have a call line and on-hold messages, internet resources, and letters to patients to help educate the patients. So what are some of the outcomes from those first two questions? These are just some of the examples of the literature that we've developed. On the left-hand side, this is an education brochure for our patients that prints out when an order is provided, and we have those available in the waiting areas throughout our health system. Then on the right side is a front and back of a bookmark that was sent to all of our primary care providers, and we leave in the lobbies of the waiting areas. This is our website. And then recognizing that there are a lot of resources available outside of what we've developed, including the AHRQ information that was presented yesterday. The outcomes of these efforts, we had posed a couple of times a research arm that looks at combining Dr. Tamagi's risk model with a molecular biomarker. We haven't been funded as of yet, so we don't have our research arm up and running. We've developed a best practice alert. So whenever someone was, a primary care provider was in a patient record, a yellow box comes up and says this patient's eligible for screening. We proposed that to our primary care providers and they said, we have too many of those. Please don't add one more. So as of today, that's still not up based on their desire. We, early on in our program, were fortunate to partner with something called a My Family tool developed by our Genomics Institute. Patients who were computer savvy enough would answer a questionnaire before going to see their primary care provider. This was for all preventive measures, not just lung cancer screening, but included in that survey were questions that could help us to identify someone who met NLST criteria and behind the scenes calculate their risk of developing lung cancer from the PLCO model, and then show that information to the primary provider when they were seeing the patients. Unfortunately, that tool has since lost its support, so it's no longer part of our system. In the meantime, though, we learned from a quick look, 4 months of over 1,100 patients who had entered their smoking histories. Around 30% of those who used the tool were either current or former smokers. Their average calculated risk for developing lung cancer was just 0.5% over 6 years. Of those who met NLST criteria, now a smaller number, only 6 of their responses matched what was 6, which would be about a quarter of the responses matched what was in our medical record at the time. And the variance in smoking history was quite large, around 14 pack years, anything from -50 to 40. So a little bit of caution about mining data for identifying proper patients. We've had extensive meetings with our pulmonary and cardiology group to identify the group that's too sick to screen. In the area of ablative therapy, it's a very hard conversation, and we've had very little traction for hard rules. Our COPD group has said, okay, a ventilatory failure, CO2 baseline over 55, or a Bodie index over 7, those should be cutoffs, but we haven't made any inroads beyond that. The next practical questions have to do with how you're going to schedule appropriate patients. How's the test going to be ordered? How are you going to coordinate the shared decision-making visit with the test? And how are you going to provide access for outside patients? Our approach to these questions, we developed a specific order and order set. Over time, we changed the order from an order for the scan to an order to the program only. So our providers across the system cannot directly order a screening scan. We've incorporated an educational tool into that order set. Once the consult order is in place, the program then reviews that patient for eligibility, calls them if they're not eligible, and coordinates a schedule for a shared decision-making visit to be immediately followed by the CT scan for those who are eligible. And we've collaborated a lot with our radiology colleagues to track these folks. And we have a program access line. This is an example of our smart set. It's called the Lung Cancer Screening Smart Set. Includes the consult order, includes a box to consult smoking cessation for active smokers, a diagnosis code, and then this is pre-checked, and this will print out a patient, that the sheet I showed that has benefits and harms of lung cancer screening for our patients to take with them. Many of our providers don't use the smart set. Instead, they order the consult more directly. Whether ordering it directly or through the smart set, there are questions embedded within that order that help to educate the providers about the criteria that we use to determine if somebody is screen eligible. If the patient's reviewed by the program and determined to fit criteria, the CT lung screen order is placed by the program and the visit is coordinated. What are the consequences of some of our decisions? Initially, the questions that were embedded in the order became hard stops. If someone said, no, they're not in this age range, then they weren't allowed to order the test. By tracking these patients, we learned that several of them were going on to have diagnostic CT scans. So we took away the hard stop and made it more an education tool and followed up with the provider with resources to help educate them about our criteria. In the past year, we've had over 1,100 consult orders placed. In reviewing these, only 56, so much better than the first year we started, didn't meet qualifications, so they weren't scheduled, but they were notified of reasons why. We completed 441 shared decision-making visits and low-dose CT scans. So the question was, why such a gap in the consult orders placed and how many scans we were doing? One explanation would be that the patients weren't quite as interested as we are in screening. The second was that we're not making it easy enough for them to be screened. This is the Cleveland Clinic Health System. It spans several counties. We started screening at our main campus, which is the green star up there, to maintain quality and to get the systems in place. All of the scans are done at main campus, regardless of where the order is placed. Many of our patients don't want to travel to our main campus. Later this week, we're kicking off screening program meetings for 5 of our health centers that span the counties so that we can blanket the area with the same infrastructure that we've used to develop our main campus program. The next questions will be, how do you conduct the shared decision-making visit? How will you review patient eligibility? What kind of overview of the benefits and harms will you provide? What kind of decision aid will you use? How will you prepare the patients for their results? How will you incorporate smoking cessation counseling? And how will you document in order to learn and report your data? Our approach is we have the patients come to our program. We have a nurse practitioner who's now performing the shared decision-making visits, who'll ask about age, smoking symptoms, and their general health. We've developed a narrated slideshow about 6 minutes in length that describes the benefits and harms of screening. We use the shared decision-making tool developed by University of Michigan, shouldiscreen.com, to show individual risk and benefit. And we discuss what the likely findings are, what the categories mean, and that finding a nodule is the norm in our program. We stress annual screening, decide how to communicate the results to our patients during that visit. And we connect patients to local resources for smoking cessation, and our nurse practitioner has been trained as a counselor. We have a templated note for that visit with extractable data elements that populates our screening registry. This is an example of some of the questions that are asked, both to determine eligibility and to collect information about patients' risk. Each of the colored areas is an extractable field that automatically populates our registry. If the patient seems to be eligible, they'll then watch a 6-minute video, a narrated slideshow that describes benefits and harms. We then use the shouldiscreen.com tool, calculate their risk for them, show them their risk and what the trade-off of benefits to harms are for a person with that risk. We then document that we've had all of these discussions and that the patient is still willing to go forward with screening. What's been the impact of our shared decision-making visit? We have about 423 shared decision-making visits over the last year. Around 5% of those patients did not go on to have a low-dose CT. About half of that 5% was by patient choice. About a third was because they didn't meet criteria, and the remaining small portion was because the patients were symptomatic and we shifted them down a diagnostic pathway. What was the impact in terms of patient knowledge and understanding of screening? The top graph represents the age range that patients thought. There were 125 patients surveyed for this, and the y-axis is the number of patients. The age range that patients thought qualified for lung cancer screening. And you can see it's very low in the area where we accept screening. And immediately after the visit, those numbers were much, much higher. Looked at in a different way, and I'm sorry, the pointer's not working very well, but the orange bar is those who were incorrect before their visit. Immediately after the visit is post, and then 1 month after the visit, we resurveyed patients, and we found they lost some of the knowledge, but not all of it. And the bottom is what is the smoking criteria to be screened. Again, you see early on the patients came in, even after having been potentially counseled by their primary care provider with very little knowledge about smoking history in the pre-visit, much better knowledge in the post-visit, and preserved knowledge, but not perfectly preserved in the 1 month post-visit. When we asked about benefit with a very liberal definition of benefit, their results were a little bit better. They could identify that we were looking for cancer, but the counseling visits seemed to improve their knowledge, and that knowledge seemed to last. Same as harms, very little knowledge about the harms of screening, and here just asking for any one harm to be described, and much better knowledge after the visit. The next question every program would have to ask is about how they're going to perform the low-dose CT. Being a pulmonologist, I'm not qualified to speak more than showing you the ACR-STR's guidelines. We have close collaboration with our radiologists who have implemented this and are tracking our radiation doses and making sure that we're staying under what's recommended. The next question that a program will have to ask is how you're going to communicate the results. That includes what kind of structured radiology report, how you're going to report the other non-nodule findings, how you're going to communicate with the patients and the providers. We had a homegrown structured report, and that's evolved to LungRads, largely because of the need to report our data. We've automated data abstraction from that structured radiology report. We have a section that's text dictated for other findings, and we're working to template that better as well. We give patients options at the time of their shared decision-making visit to come back up the same day, receive a phone call, and they all get a letter, and we have a means of electronically communicating with them. based on the severity of the result, we certainly will speak to them if it's category 3 or above. How do you communicate with the provider? In very similar ways. This is an example of our structured report, again, based on lung RADs, and all of these elements are extractable. This is an example of our category 1 letter to our patient, explaining that there was nothing concerning finding and that we'll see them in a year, stressing the importance of the annual screen. Category 3 gives the percentage risk of being cancer based on lung RADs and stresses the timing of their follow-up scan and the need for that follow-up to occur. How to manage abnormal findings. A question the program will have to answer is, do we centralize or decentralize management? How do we watch the low-risk nodules and manage the intermediate and high-risk nodules? And how should we manage those other findings? Finally, how will we track patients? As I've mentioned, we've evolved to a centralized approach where we own all of the results. We use lung RADs follow-up for the low-risk nodules. We've developed a care path for the intermediate and higher-risk nodules. Any biopsy that is being considered is discussed at a tumor board before the biopsy occurs. We've collaborated with relevant specialists in other areas to manage other findings. We have our internal registry, and our radiology team has purchased a management tracking system that we're just getting in place. This is an example of our care path for these category 4 nodules. We've screened over 1,100 people, and we're kind of proud to say we've had 2 potentially avoidable biopsies, so biopsies for benign nodules. First, a 16 millimeter, very PET-avid nodule that bronchoscopy was negative for. Follow-up scan, the nodule had shrunk. The second, a lung nodule that after PET imaging had a risk of about 10% of being cancer, and a transthoracic needle biopsy was negative. Patient I saw last week, his nodule shrinking a bit, and he said, boy, I really wish you would have argued me out of that biopsy after he had insisted on it initially. We've looked at guidelines for thyroid nodules, adrenal nodules, coronary artery calcification, and thoracic aortic aneurysms. We found that over a third of our patients have a pulmonary or cardiovascular abnormality on their imaging. We found that 13.9% of everyone screened ends up with a consult to another service, and about 12% gets other testing done. How do we ensure compliance with the annual screen, and do we include a shared decision-making visit at the annual screen or just during the first screen? Compliance is ensured with an internal registry in our management tracking system. We send letters and make phone calls. We believe that the shared decision-making visit will be of value at each of the screening times. We think the patient's knowledge will wane a little bit over time. There may be new information that we can present, another face-to-face opportunity to develop a relationship and to stress smoking cessation and to reassess their compliance or their eligibility. This has been a major challenge for our program. In the era before we centralized, when the scans were being paid by the patient, we only had 35% compliance, no matter how many letters or calls were made. In just a short time frame now, too little data to really discuss, we're up to about 2/3 compliance with screening. How will your program include smoking cessation? We've incorporated that into our shared decision-making visit. We connect patients with tobacco cessation programs locally, highlight community resources, and our nurse practitioner is now a trained smoking cessation counselor. These are some of the resources that we point our patients to, print this out for them. These are broader and then more local resources for free smoking cessation. How do we collect, report, and review data? How are you going to collect relevant required data and communicate that data to the National Registry and use that for program improvement? Be questions that we all have to answer. We have an internal registry that pulls from the order set, from the structured radiology report, from our shared decision-making visit note, and from our electronic health record. We are also testing commercial software at this time. We communicate through those sources, and we evaluate our program fairly often with some iterative improvements, as I've discussed. This is our results from all of that data collection, separated from before we were fully centralized to after. We think the quality has improved. We have far fewer outside the age range that qualifies for screening or outside the smoking range. In our program, 90% of everybody screened has a lung nodule found. 16% of those are category 3 or category 4. We've had the 2 avoidable procedures, and we've had 11 lung cancers out of 1,100, about 1%, and we found 7 other cancers through screening. Over time, all of this has only been possible by building a team of collaborators who I'm just fortunate to work with, from our primary care providers, radiologists, surgeons, other specialists, our advanced practice providers, administration, marketing, billing, scheduling, and EHR and IT specialists. So again, thank you very much for the invitation, for your time. I think in summary, development of effective high-quality lung cancer screening requires a recognition this isn't a test, but a multifaceted program. We need teams with broad expertise and shared vision and support from our administration who respect the value of these programs to the system. Again, thank you very much.